Right. So let us make the start with bone tumors. Without a question on bone tumors, there is no entrance exam. So let us be very sure on this important, very high yield topic. Right. I am happy to know that the voice is clear. So yesterday we had a day-long session on neurology in Guntur with stalwarts like students from Guntur, NRI and so many medical colleges. So even in our, after the orthopedics is over this week, next week onwards we will be starting general medicine. So for the next 5 weeks I will be reviewing general medicine for all of you. You're all welcome. Please do come. Now, in the bone tumors, what is the most common source of the bone tumor? It is the metastasis from somewhere else. Somebody smoked throughout life, developed bronchogenic carcinoma, and the bronchogenic carcinoma goes to the brain and bone. Lung cancer, prostate cancer, breast cancer, anything can metastasize, and that is more common than the tumors arising within the bone itself, the primary bone tumors. That's a point you need to basically appreciate. The examiner has a very tricky way of asking this question. If he asks, out of all the primary bone malignancies, what is most common? What is your answer? Multiple myeloma is commonest. And what is the commonest benign tumor of the bone? It is the osteochondroma is what you have to ultimately remember. Basically, osteochondroma is considered not a true tumor but a tumor-like condition of the bone. So, though it is the commonest benign tumor of the bone, it is not the commonest true benign tumor of the bone. English is the nasty language. So, be very sure. Okay. So, the examiner asks, commonest benign tumor of the bone is osteochondroma, but commonest true benign tumor of the bone, then it becomes osteoid osteoma. That's the point you need to basically appreciate. So what is osteoma? Let's start with the first tumor. It's a benign tumor. It is sclerotic, well-formed bone-producing tumor from the cortical surface of the bone. That is, a tumor by itself is capable of producing the bone. It arises from the bone and produces the bone, hence called as osteoma. It is the skull, calvarial bones and the facial bones are the ones which are most commonly involved. And whenever the osteoma is found, generally it has no clinical significance. The only thing is, it looks like a swelling and patient is worried. Shadi.com, I want to put my photograph. This osteoma is interfering. Will you remove it, doctor? That's the only reason. So this is an example of a typical osteoma which is producing a prominence on the calvarium. This is another example of an osteoma which is occurring in the paranasal sinuses. In the ENT, osteoma once more will come back to you. Sometimes it can present in the frontal or ethmoidal bone like a swelling in the air sinuses and can lead to obstruction of the sinus cavity, leading to pain. That can be the presenting feature in some scenarios. Generally, what do you want to do for this? Nothing need to be done. There is no treatment really required and it is not considered to be any pre-malignant lesion. Osteoma, lot of times this question was asked as an MCQ, which is not a pre-malignant lesion. Osteoma is not a pre-malignant lesion. Then comes osteoid osteoma. If the examiner asks a question, commonest benign tumor, true benign tumor of the bone, that becomes osteoid osteoma. So what does osteoid osteoma contain? Dense sclerotic bone. Dense. If you happen to look on the radiograph, it looks like a white paste. So dense sclerotic bone is a typical appearance and it contains a nidus. One nidus which is being surrounded by a dense sclerotic bone. So this nidus basically contains mineralized osteoid trabeculae. are the component of this nidus. I will show you the nidus. See, this is called as the nidus, which is being surrounded by dense sclerotic area. This is the nidus and sclerotic area. Are you able to appreciate? A nidus surrounded by dense sclerotic area. This is characteristic feature of the osteoid osteoma, is what you have to basically remember. What is the age group? 5 to 25 years is the common age group where you will find this. Commonest site of osteoid osteoma, favorite MCQ in entrance. 3 things you have to remember about every tumor, doctor. Commonest site, is it epiphyseal, metaphyseal, diaphyseal. What is the age group where it will occur? Will you do resection or not? Will you give chemotherapy or not? 5 aspects on every tumor. Okay? Osteoid osteoma is a very special type of tumor. Why? Because most of the tumors are either epiphyseal or metaphyseal. Nothing is diaphyseal. What is diaphyseal? Shaft of the bone. Shaft of the bone. If at all there are only 2 tumors which are there on the shaft of the bone, you should remember, one is osteoid osteoma, Ewing sarcoma. They are the only tumors which are there on the shaft of the bone, is what I want to underscore to all of you. Then the osteoid osteoma can even involve vertebrae. A vertebra has got a vertebral body, anterior elements and posterior elements. It is the posterior elements, that is the spine and other structures. They are the ones commonly involved in the osteoid osteoma, is what I want to once more reinforce for you. If you take the gross cut section, you find one nidus surrounded by a sclerotic zone which characterizes the osteoid osteoma. And this is a typical trabeculae which are mineralized, which form the nidus, is what I want to reinforce for you. Now there is another very characteristic feature of the osteoid osteoma you should not forget in exam. Typically patient complains of nocturnal pain, excruciating pain, and you prescribe him salicylates. Wonderful relief will be there. This is one of the favorite question of the examiner. A nocturnal pain relieved by salicylates, where do you see? Osteoid osteoma, is what you have to emphatically answer. Let me tell you, doctor, if the All India MD entrance is for 300 marks, it is only for 299 marks, because 1 mark is bone tumors. If AP PG exam is 200, it is only for 199, because 1 mark is bone tumors. उत्ता पक्का आने वाला टॉपिक है, पॉकेट में लगा के जा सकते एग्जाम को. Definitely you should read everything, anything about it. Okay, so salicylate responsiveness is a very classical feature in case of osteoid osteoma. So how will you basically diagnose, doctor? You will take a X-ray. X-ray will show the presence of a radiolucent nidus surrounded by zone of sclerosis, and even you can use a CT scan in order to demonstrate the presence of the nidus along with sclerosis. Let us see. This is a typical vertebrae, and a nidus with surrounding sclerosis is what you are able to demonstrate in the vertebrae. Another common location, posterior elements of the vertebrae is a common location. So how do you treat, doctor? You can do excision of the nidus along with the sclerotic bone. Generally prognosis is very good in osteoid osteoma, and it is not considered to be pre-malignant lesion. The 5th important aspect you should always remember about the benign bone tumors, other than site, most common location, etc., is will it become malignant, will it not become malignant? So what is your answer for osteoma? It will not become. Osteoid osteoma, it will not become. That is what you need to remember. Now let us talk about osteoblastoma. 5-6 points which are very crucial for examiner. Osteoblastoma. Osteoblastoma is also a benign tumor. Speciality of the osteoid inside it is a vascular osteoid. Vascular osteoid is what you will typically see. And where do you see osteoblastoma? It is the jaw. Bailey and Love, you have one topic on, we don't read generally, topic on tumors of the mandible, jaw and dental, little bit of dentistry related things. Okay, so jaw and the spine. Whenever the osteoblastoma occur in the long bones, it is either diaphysis or metaphysis, but never in epiphysis. That is a very important rule. Just like osteoid osteoma, you remember that it is the rare diaphyseal tumor. I mean, it is rare in location. Most of the tumors are metaphyseal or epiphyseal. Diaphysis is only osteoid osteoma. अगर ऑस्टियोब्लास्टोमा है तो इसका स्पेशलिटी क्या है कि वो डायाफाइसिस में हो सकता, मेटाफाइसिस में हो सकता, एपिफाइसिस में कभी नहीं होगा. That is what you need to basically remember. And when you see osteoblastoma, we are very blastic in the second decade of our life. So that is the time, second decade of the life, it is very, very common. This is an example that vascular osteoid of an osteoblastoma is a very classical feature. And whenever you happen to take a radiograph, what type of lesion it is called? Geographic lesion with mild sclerosis which is surrounding it is a very, very characteristic feature. Geographic lesion, it's called as, described as. This is a MRI T1 weighted image of an osteoblastoma of the distal femur. It is a well circumscribed geographic lesion with an increased signal intensity on T1. Then, how will a patient of osteoblastoma present? Aching pain, classically, just like in osteoid osteoma. And it has got when you look at the bone, it presents like a radiolucent expansile bone lesion. It can be diaphyseal or metaphyseal, but never epiphyseal, growing end of the bone. And if you look for always bony sclerosis. In case of osteoid osteoma, there is intense bony sclerosis around the central linus, but osteoblastoma may very minimal reactive new bone formation will be there, which is characteristic. So how do you treat, doctor? You treat by doing curettage, is considered to be the management of choice. This is once more on the sternum. Osteoblastoma classically will be presenting on the sternum is what you need to basically remember. Then comes Chondroblastoma. Osteo is bone has blasted. Now cartilage want to blast. Chondroblastoma. What do you want to remember about it? It is a cartilaginous tumor. Cartilage means you will remember mineralization. Containing a lot of calcium deposits is the description of chondroblastoma. And it also occurs in young individual and it is located in the epiphyseal plate. Osteoblastoma कभी भी epiphysis में नहीं होगा, मगर chondroblastoma होगा epiphysis में. So this is very important to remember. And which are the bones commonly involved? Typically, the bones around the knee are commonly involved. How will you remember? Generally, what will orthopedic surgeons generally tell? Knee joint cartilage is eroded, hence osteoarthritis, I want to do knee replacement. So cartilage means first structure that comes to our mind is knee. So cartilaginous tumor also, first structure to come in mind is knee. So knee is the most common site for the chondroblastoma. So how does it present? There is a well defined but a lytic lesion surrounded by zone of sclerosis is the classic description. Now let us see. Are you able to see a lytic lesion which is lucent surrounded by zone of sclerosis? This is how in the knee joint and the tibia you are able to see the presence of a chondroblastoma is what you have to basically remember. Similarly, typically it is a chondroblastoma lytic lesion surrounded by a sclerotic zone. Lytic lesion surrounded by a sclerotic zone. In this case, in the patella, you are able to see. So this is the typical description. Chondroblastoma, knee joint, you are not going to basically forget. Besides, chondroblastoma there is a lot of calcification. Because of all that calcification, how will a chondroblastoma look like? It will have a mottled appearance. Is a very, very important point. Many times asked in entrance, MD entrance exam, which bone tumor has that mottled appearance? What will you remember? Chondroblastoma, due to the calcification into that. And how do you treat, doctor? Curettage with bone grafting is considered to be the management of choice. Then if you look at histopathology of chondroblastoma, there is a very important pattern in which calcification is seen. That's called chicken wire calcification. You go to previous AIMS All India question bank. Many times this question was asked. Chicken wire calcification, where do you see? Chondroblastoma is what you need to remember. This is a typical tumor cavity. What will you do for chondroblastoma? Curettage. So how will you remember the curettage and the chicken wire together? When you cook the chicken, when there is a great demand, you have to do curettage in order to serve everybody the good dish. So someday, don't tell, Dr. Murali teaches like this, right? I'm basically a MD in general medicine, but we tried with lot of orthopedic surgeons. Even among orthopedic surgeons also, we found that those who do replacements, knee replacements, don't touch malignancies. Those who do disc prolapse surgery, throughout life they will be doing disc prolapse surgeries only. They don't touch anything else in the body. If they touch, that will spoil. So they become too focalized. So undergraduation may orthopedics is a super specialty subject, right? So you need to know 40 topics, 10 points in each topic, except bone tumors, it's a little bit topic. 500 to 600 points you go and go to exam, 10 questions you will blast and come. 10 out of 10 marks you can get. So my idea is to make you in the next 5 days to come to be fully ready with orthopedics, so that no fear about orthopedics. That's what we want. Okay. So this is the tumor cavity with curettage is what is being done. This is the cryosurgery. You are pouring hot boiling water into the chicken. So this is the cryosurgery, not hot. Cryo means cold. Cryosurgery of the tumor cavity. And bone grafting and closure is what you will do. Curettage, cryosurgery, bone grafting and closure. And this is another example of a proximal tibia's chondroblastoma, where there is a mottled calcification. Is another important appearance on the sagittal MRI, is what you are able to see. Then this is another example of a proximal tibia. What are you doing here? Curettage resection and chondroblastoma. You are not going to basically forget. Then comes Hemangioma of the bone. What do you want to basically remember? Basically, Hemangioma, as the name itself says, is a tumor of angiomatous origin from the vessel. Commonly it is a vertebrae and the skull are the two favorite locations for the hemangioma of the bone. So how will it present? Since it is arising from the vertebrae, it can lead to compression of the cord, and it can also lead to development of a persistent pain, is another important presenting feature. Now in the vertebrae you have cervical, thoracic, lumbar, sacral, coccygeal, which is the most common location. Lumbar vertebrae is most commonly affected. How will it appear when it is involving the vertebrae? Favorite MCQ in exam. Normally a vertebral body is supposed to have horizontal striations and vertical striations. Whenever hemangioma occurs, those horizontal striations are lost and the vertical striations get prominence. And we call corduroy jeans. When you wear corduroy jeans, how will be vertical striations are very prominent in a jeans, corduroy jeans they call, no? So that is how it will basically present. Are you able to see vertical striations like a jeans pant? Corduroy jeans is a typical appearance on a T2-weighted sagittal image, because the prominence of the vertical striations is what you need to basically remember. Right. So I am very happy to see our online students after a long time. I am missing the 5 to 8 class. So generally if we conduct weekend classes on Sunday, maximum we can teach about 8 hours. First 2-3 hours you are attentive. After that it is pain for you and pain for us. But somehow we will pull to the end. That is more unphysiological way. So this is more physiological. Read entire day. Evening 2-3 hours you spend in listening a lecture and then happily go home and sleep. So that's how you can be able to plan the day. So good. So this is a typical vertical striations in the vertebral body is what you can classically see in case of hemangioma. This is also a hemangioma. And since you have cut it and vertical striations are very prominent, it looks like perforated appearance. That's important. For the differential diagnosis, whenever the vertebral body is involved, a mass lesion is found on vertebral body reported by the radiologist. Now what are you going to do? It can be TB spine. It can be a metastasis to the spine. That also can present like a lesion in the vertebrae. But how do you differentiate? Suppose if it is a metastasis to the vertebrae, it will be localized only to the vertebral body without involving intervertebral space. If it is tuberculosis, it will involve body and also intervertebral space. Intervertebral disc space is there, that become obliterated. So that is how you will recognize that. So you need to be quite sure whether it's a benign pathology like hemangioma or a treatable pathology like TB or a variable pathology like malignancy, metastasis is what you should be sure. So how will you treat hemangioma, doctor? Radiotherapy is considered to be the management of choice. Then comes Adamantinoma. Adamantinoma is a tumor of the jawbone classically, and even on the tibia, especially in the lower half of the tibia. Very few tumors are in the lower half of the tibia as a favorite place towards ankle. Adamantinoma is one such tumor. Between 10 to 35 is the age group. Unlike the other benign tumors which are painful conditions, you take hemangioma, painful, osteoid osteoma, painful, osteoblastoma, painful, but adamantinoma only minimal pain and it increases in the size gradually. And what is the classical appearance of it on X-ray? It has got a honeycomb like loculated lesion is the typical description of the adamantinoma. And if you do the resection is the treatment, but local recurrence is very common. That's the problem with adamantinoma. But adamantinoma in the jawbone, you should not basically forget. Let us see. This is an example of which bone, doctor? Tibia, lower end of the tibia. The presence of what kind of lesion you like to call this as? Honeycomb. Honeycomb which is hanging. Are you able to feel a honeycomb in that? You have to. So that is lower end of the tibia, adamantinoma. Okay. Then comes the chordoma. Chordoma is also called locally malignant tumor. So it is oma. Oma always does not mean benign tumor as told in Robbins pathology. First chapter is when we studied pathology. What is oma? What is coma? So many things will be there. No. From where will it originate? Notochord. Embryologically, from which chordoma will arise. Two common sites for the chordoma, sacrum and cervical spine are the two common sites which you should not basically forget. And there is a persistent pain. This is also a painful condition, and there is a swelling. And sometimes because it is very close to the nervous system, it can lead to compression and lead to development of neurological deficit. So sacrum, cervical, they are the two common locations for the chordoma. Now, whenever the chordoma occurs, it will destroy the bone. So that bony destruction is one of the important hallmark in the radiological appearance of it. So how will you treat? Complete excision. and also radiotherapy. They are the two important parts of the management. Now let us see. What is this area? Sacrum. In the sacrum you have a sacral chordoma. Because of that the sacrum got destroyed, and that is the place where your chorda equina will be passing, and that can also undergo compression. So that's the reason you should consider this is a classical example of chordoma, sacral chordoma. Okay, radiotherapy, excision are the main part of the treatment. This once more a gross appearance after you have removed how a chordoma in the sacral area basically looks like. Then comes the giant cell tumor. Generally, if you look at most of the giants, they are very good people. We are scared about giants that they will eat us. No, they won't. And the world may, the most cruel dictator Hitler was very short, he was not giant. So being short, he made the entire world shiver. So giant cell tumor looks giant, but it is basically classified as benign. But what is a little atypical about its benign nature? Generally benign tumors recurrence is less common, but it will recur if you happen to do local removal of a giant cell tumor. Now why it's called giant cell actually? Not because of its size it is called giant. When you look histologically, there are multinucleate giant cells, hence it is called as giant cell tumor, and there are spindle cells which are undifferentiated along with multinucleate giant cells are there in the histology, hence called giant cell tumor. This is a highly vascular tumor, giant cell tumor, and these giant cells which are often mistaken with multinucleated osteoclastic cells in the bone. That's the reason earlier days they used to call it as osteoclastoma, but it is not originating from osteoclast actually. That's the reason the giant cell tumor is the name which is being retained. That's what you need to remember. Now let us see. This is the classical appearance of what is called as a giant cell tumor. Which is this location, doctor? Radioulnar joint, radius ka lower end. Once more, this is an example of a large, well-defined mass extending into the subchondral area, which is basically called giant cell tumor. What is the age group where you see this? 20 to 40. After you became giant, I mean your adolescence is over, your teenage is over, 20 to 40 is the time where giant cell tumor is seen. It is the lower end of the femur, upper end of the tibia, knee joint once more, is the favorite location around the knee. Even the lower end of the radius which we have seen in the earlier radiograph is also a common location. And this is a typical epiphyseal tumor, giant cell tumor. Let us see. Where is this tumor, doctor? This is lower end of the radius. And this guy looks like a child's hand or a 20 to 40 hand. It is definitely not child, but 19, 20, 21 kind of a guy. And it is epiphyseal in location. It will reach almost to the surface of the joint because it is at the growing end. It will lead to a swelling and a vague pain, and sometimes pathological fracture is the typical presentation with which the giant cell tumor will be presenting. So how will you describe the swelling as? Eccentrically located. Bone is swelling at the end of the bone, which is tender if you try to do firm palpation, is a classical description of the giant cell tumor. And what is that important finding on clinical examination? Egg is there, no? Egg shell will give that crackling appearance. That egg shell crackling is the typical sound that you listen while examining the giant cell tumor, not always found. Don't try to do too much, that egg will break down. So eggshell crackling is what you need to remember. Now this presents like a eccentrically placed solitary bone lesion towards the epiphyseal end of the bone. Any other tumor which presents like a solitary bone lesion becomes a differential diagnosis. So what are the other conditions which also present like a solitary bone lesion? Giant cell tumors, simple bone cyst, aneurysmal bone cyst and fibrous dysplasia. The four conditions which present like a solitary bone cyst. So how to differentiate one from the other is a favorite MCQ in entrance. Out of all this, only giant cell tumor is epiphyseal. All other are metaphyseal. Radiological appearance may, what is the speciality of the giant cell tumor? That soap bubble like appearance. Are able to see and appreciate that, doctor? Soap bubble appearance in the earlier radiograph. This looks like a soap bubble. Are you able to, did you anytime blow soap bubble? This time you blow and see, is that that the end may, I mean, there are some striations in that lucent flying structure. So soap bubble appearance is the classical feature. It is eccentrically placed, and what is the treatment for the other conditions? If you take simple bone cysts, aneurysmal bone cysts or fibrous dysplasia, you do curettage and bone graft. Whereas for this, you have to do excision. That is the speciality of giant cell tumor. So I leave the literature for you. Tomorrow by the time you come, they will keep the notes ready. Notes ready. And from Monday onwards, we will be starting general medicine with cardiology. So cardiology and neurology. The notes is already made ready. Tomorrow when you come, please collect that. But this Sunday, forthcoming Sunday, the last full day class we arranged. We have Dr. Deepu Sebin, who is flying from Bangalore to Hyderabad to deliver morning 9 to evening 6. Rheumatology he will teach. That will be in the general medicine. Only one session is full day, morning to evening. Remaining sessions are all we planned Monday to Friday. That's more easier, more comfortable sessions. Another 4 weeks may we complete entire general medicine. That's the plan. Okay. Now, doctor. Yeah. How do you basically make the diagnosis? Shweta is asking, what about patho and microbiology? I think path and micro had enough path, enough micro. After general medicine, if time is there, we will see. But most of it, majority of it is live class is done by last week. But anyway, we have lot of videos in the online video library. Now, where are we, doctor? So what are the important characteristic features of giant cell tumor? Solitary lesion, subchondral eccentric location, expansion into the overlying cortex, soap bubble appearance. These are the classical points you need to remember. Soap bubble like appearance of the tumor is the classical feature of giant cell tumor. No calcification into the tumor. One of the favorite MCQs of the examiner. Giant cell tumor में calcification नहीं होगा. And no reactive sclerosis. Unlike the other tumor, benign tumors में हर एक में एक reactive sclerotic margin है ना, इसमें नहीं होगा giant cell tumor में. That is very important. The cortex is very much thinned out. Because of this expansile lesion, bone cortex become thinned out and pathological fractures can occur into that. And will the giant cell tumor encroach into that adjacent joint? That is never the nature of the giant cell tumor. It is eccentrically located, it is located towards the epiphyseal end, they are all true, but it won't walk into the joint space. That's the point you need to appreciate. So what is the differential diagnosis for a solitary lytic bone lesion is what examiner would be interested. Very frequently asked MCQ. You can remember fog machines. F for fibrous dysplasia, osteoblastoma, giant cell tumor, aneurysmal bone cyst, chondroblastoma, non-ossifying fibroma, etc. etc. Okay. Then, why did you call them as giant cell tumor? Because what you have here, multinucleated giant cells which are mixed with spindle cell containing stroma is the classical description of giant cell tumor. And this is a typical appearance where it is multiloculated, honeycomb or soap bubble, whatever you like to call it as. So what is the treatment of a giant cell tumor? Excision of the tumor, radiotherapy, especially when giant cell tumor occur in the spine, radiotherapy, and in which scenario excision is considered to be the best way of treating this tumor, doctor? Whenever it is occurring in the fibula, in the lower end of the, or in the lower end of the ulna. Fibula, ulna are like the youngest brother in the family. Big brother is always radius and tibia. So whenever it is occurring, fibula or lower end of the ulna, even if you remove it also, still it will not impair the function. If tibia is injured, walking becomes difficult, but fibula is injured, nothing will happen. Removed. But of course, fibula's upper end may common peroneal nerve will be passing. I am not talking about that. Any part of the bone of the fibula, if you remove, nothing will happen. That's the reason fibula is often used for bone grafting. That's very important. Then whenever you do excision, following excision, reconstruction as a management of the giant cell tumor. Suppose if it is affecting the lower end of the femur, then you will be removing it en bloc, and whatever the defect which is being there created by that, you will basically treat it by doing arthrodesis with turnoplasty or arthrodesis by bridging with a fibular graft, or you will be doing arthroplasty. Any of the methods you will try to fill that gap which is being created, which is called excision with reconstruction. So this is an example of a wide excision of the tumor mass, and this is a ulnar stump stabilization using the extensor carpi ulnaris. And sometimes to treat giant cell tumor, we will be doing curettage with or without supplementary procedures. So when will you do that? But the only pitfall of the curettage is if you do curettage for giant cell tumor, recurrence rate is very high. So that's a point you need to remember. We also do cryotherapy as another important option for management of it. And we do the thermal burning of the residual cells after doing the curettage. Whatever that is left over, we can do the thermal burning. And then we apply the bone cement. So there is another option which is available. Then another important treatment option whenever giant cell tumor is there is especially when it is very aggressive. Every time you are resection it is recurring. Then amputation becomes the only choice which is available. Then radiotherapy is another option which is available, especially when giant cell tumor affect which location, doctor? Spine, vertebrae. This is another commonly asked MCQ in entrance exam. Giant cell tumor of spine, what is the treatment of choice? Radiotherapy is considered to be the management of choice. Then the common sites and how do you treat is a very important question. Good. Vaishali and Shweta are saying anat physio, skin anesthesia, radiology, psychiatry. We will finish those subjects once medicine is over. Then we will have gynops. Dr. Shilpa has delivered a nice baby boy, and by the time another 1 month passes, she can be able to come to teach gynops on the wonderful evenings like this. After that, we will do the remaining subjects. We have no other work across the year. To keep on teaching is our only job. So that's the plan. Now, how do you treat giant cell tumor at common sites? This is a favorite MCQ, doctor. Each of this is asked many times in entrance. Lower end of the femur, whenever it occurs, you do excision with turnoplasty. Upper end of the tibia, excision with turnoplasty. Lower end of the radius, excision with fibular grafting. Lower end of the ulna or fibula, if it is occurring, only excision. And within the fibula, which part of fibula you will remove whenever the fibular grafting has to be done. We basically choose proximal end of the opposite fibula is the one which is basically preferred. That is all the story of giant cell tumor. Any question, anywhere, any type, you should answer. Okay, doc? Now, osteosarcoma. There are totally 4 malignant tumors now we are going to master. We finished what are all the benign tumors? Osteoma, Osteoid osteoma, Osteoblastoma, Chondroblastoma, Hemangioma, giant cell tumor, Chordoma. Right? The 7 or 8. Now another 5 malignant tumors. Khatam. Bone tumors, you are king. Carry it in your pocket. 1 mark definitely you will get it. At least 1 mark out of 200 marks. Be sure. Osteosarcoma. Highly malignant primary bone tumor. From where is it arising? Mesenchymal cells. Mesenchymal cells. It will be arising, and it is a tumor which is known to form osteoid. Earlier also in benign tumors we have one of the tumors which is forming the bone by itself. Which one? Osteoid, osteoma or osteoma. Right. So it is also among malignant tumors. Osteosarcoma produces bone. Tumor cells secrete bone. That's the point. So this is a typical thigh bone is a classical location for the development of a osteosarcoma is what you need to remember. Note the classification. Osteosarcomas are broadly divided into primary osteosarcomas and those which arise from some other underlying bone condition called secondary osteogenic sarcomas. So primary osteosarcomas, they are much more common than the secondary, and common age group is between 15 to 25 years is the common age group. And if you take those which arise from some other condition, that is secondary types versus primary types are much more malignant compared to that of the secondary type of a osteosarcoma. 15 to 25 is a common age group for primary, but above 45 is a common age group where secondary osteosarcomas. Suppose if Paget's disease is there, Paget's disease is also pre-neoplastic and it can convert pre-malignant and it can convert into osteosarcoma. When an osteosarcoma arises from the Paget's, then the age group is 45 and above is what you need to remember. So Paget's disease, multiple enchondromatosis, fibrous dysplasia, any radiation, multiple enchondromata, anything can be precancerous and can lead to development of osteosarcoma is what need to be basically remembered. Now what are the different types of osteosarcoma? Osteoblastic, chondroid, fibroblastic, telangiectatic. Telangiectatic is also called osteolytic type of a osteogenic sarcoma. So whenever osteosarcoma metastasizes, it goes to lungs. What type of metastasis they are? Vascular metastasis. Common MCQ in exam. What are the 3 tumors which are notorious to produce vascular pulsating hemorrhagic metastasis into the lungs? In gynecology, obstetrics, choriocarcinoma. Then renal cell carcinoma. Then in the bones, osteogenic carcinoma, osteogenic sarcoma, osteosarcoma. They are known to produce vascular pulsating metastasis to the lungs is what you need to basically remember. And out of the 4 varieties which is more malignant in nature, osteolytic is more malignant. And in spite of all the aggressiveness, osteogenic sarcoma will never go and penetrate the epiphyseal plate and encroach into joint. That is the discipline it will maintain, osteogenic sarcoma. Now, Let's talk about each of the varieties. Primary osteogenic sarcoma. Common age group is what, doctor? 15 to 25. And if I say the commonest musculoskeletal tumor, if at all a tumor occurs of all tumors in the age group of 15 to 25, it is osteogenic sarcoma. In the age group of 15 to 25, most common tumor becomes osteogenic sarcoma. Metastases don't occur at 15 to 25. From other organs to the bone, metastases generally overall are most common, but they don't occur in that age group. So, what are the common sites where osteogenic sarcoma typically is found? Lower end of the femur is the most common site, favorite MCQ in entrance for the osteogenic sarcoma. Upper end of the tibia, then upper end of the humerus. Forget about second, third, nobody will ask. First only they will ask. So, lower end of the femur. If you are still getting hallucinations while reading textbook that suddenly second most common location for the tumor examiner going to ask me is a kind of feeling, if you are means you are most insecure student preparing for entrance. They will never ask second or third. They will only ask most common, and that should be your answer, lower end of the femur. Let us see, the lower end of the femur, you are having a huge tumor which is basically compared to the other side. How is the surface of it? When you throw light, shiny, very shiny. Now, from where is the osteogenic sarcoma arising? Mesenchyme. That's the reason histologically what you find, anaplastic mesenchymal parenchyma with the tumor cells which are producing osteoid, new bone, is the classical appearance is what you need to remember. So what are the important clinical features of osteogenic sarcoma? Pain. Pain usually is the first symptom followed by swelling, classically. What kind of pain you call it? You call it as constant and boring type of a pain, and sometimes it can lead to pathological fractures is what you have to basically remember. Then which location do you find this very commonly? Not epiphysis. Metaphysis is the typical location. Between diaphysis and epiphysis you have metaphysis there. It won't encroach into the joint space. That's the second thing about osteogenic sarcoma. And how is it? Surface shiny, prominent veins is a classical feature. It's very warm and tender. And if you look at the margins of the swelling, you can't be able to feel where are the margins. Earlier you have seen that it is not like you can feel the margins, you can't feel. It is like a tight big swelling which is shiny surface. And it can compress on the surrounding neuromuscular structures, and the regional lymph nodes can be enlarged. Generally sarcomas don't go to lymph nodes, right? But in this case regional lymph nodes, not because of metastasis of osteogenic sarcoma to nodes, because of the reactive lymphadenopathy, regional lymph node can become enlarged. So this is an example. Is it encroaching into the joint space of the shoulder joint? No, it's not encroaching. It is typically metaphyseal. Are you able to see its margins? No. And typically it has got a shiny surface. That is the appearance of osteogenic sarcoma. This is another example. You can see huge osteogenic sarcoma. Okay, don't confuse. This is not thigh. This is thigh and this is leg. But it got so big swollen. And is it encroaching into knee joint? It is not. So that is the speciality of osteogenic sarcoma, is what you have to basically remember. So what do you see on X-ray? Destruction of metaphysis which is irregular, and the overlying cortex is eroded, and there is a new bone formation, and there is an intense periosteal reaction. And how is that reaction? Periosteal reaction. Based on the type of periosteal reaction also you can make diagnosis. The periosteal reaction is basically irregular in nature. What is the difference between, what is the importance of this point? If it is any infection, let us say osteomyelitis. There also periosteal reaction will be there, but that will be smooth and regular, unlike irregular periosteal reaction is what you need to remember. And what happens? Basically, it leads to development of lifting of the periosteum. And what is this called as? Codman's triangle. Because the lifting of the periosteum by the tumor's periosteal reaction, there is development of lifting of the development of Codman's triangle is very classical. This is another example. A destructive lytic lesion in the metaphysis on the medial aspect of the femur with a new bone formation and the periosteal reaction with the lifting of the periosteum leading to the development of Codman's triangle is a feature of osteogenic sarcoma. This is a T1 weighted coronal image which is showing a lytic destructive lesion with the soft tissue periosteal reaction and new bone formations is lifting the periosteum and forming the Codman's triangle is what you have to basically understand. This is a coronal still image which is showing the same lesion which is lytic and osteogenic sarcoma. So it is, what is Codman's triangle? It is the triangular shaped area in the subperiosteal location with a new bone which is being seen. Then one more important thing is, whenever osteogenic sarcoma is growing in size, what happened to the periosteum? Periosteum is supposed to contain it like a bag, but it is unable to contain it. So it will encroach into the surrounding soft tissues, and because of that encroachment, it will give the appearance called as sun ray like appearance. So two classical features you won't forget about osteogenic sarcoma: Codman's triangle, sun ray appearance are the ones which you have to remember. And all that, why sun ray like appearance? Whenever it is encroaching into the surrounding soft tissues, the new bone will be forming along the lines of the blood vessels. Hence it gives that sun ray appearance is what need to be remembered. So this is the Codman's triangle and these are the sun ray spicules, and the tumor will break down the cortex and encroach into surrounding tissues. This is what you see with the osteogenic sarcoma is what I like to underscore to all of you. This is another example of that Codman's triangle which you see in case of, on plain radiograph, in case of osteogenic sarcoma. Then what are the important investigations in the blood? Alkaline phosphatase is elevated, but it is elevated in lot of conditions, so not much of clinical significance. But one reason you should remember is the alkaline phosphatase levels after you treat osteogenic sarcoma are supposed to normalize. If that didn't normalize and remained elevated once more, that is a sign of recurrence, which is not uncommon with osteogenic sarcoma, is what you need to remember. So how will you diagnose that this is osteogenic sarcoma? You have to do bone biopsy. You have to do the biopsy to confirm your diagnosis. Now, why you want to know? Through imaging, through biopsy, etc. What is the extent of this tumor of the osteogenic sarcoma? Why do you want to know? You want to know because you want to plan the amputation. A good number of times an osteogenic sarcoma will have skip lesions into the medullary cavity. So if you only remove the area where the tumor is involved, those skip lesions will lead to recurrence and make you fail. That's the reason you need to basically worry about extent of the tumor. Are there any skip lesions? To what extent they are present? Similarly, you want to plan a limb salvaging operation. Suppose if the patient came very early stage of the osteogenic sarcoma, you can be able to save the limb when the size is very small of that. That's the reason you want to know the extension. So what are the various ways by which you can know the extension? If you do MRI or CT, you can know the presence of the soft tissue spread. If you do the bone biopsy, bone scan, radionuclide bone scan, you can be able to know the intramedullary skip lesions, how many are there, how long they have skipped, everything you can be able to know. So how will you basically treat the tumor? You have to do the local control of the tumor and for that amputation is considered to be the best choice which is available for you. And sometimes amputation need to be done for palliative causes also. If the tumor is very painful, lot of skip lesions are there, then in order to palliate also amputation is required. Earlier days what they used to do is, suppose whenever there is any osteogenic sarcoma, even the proximal joint also they used to disarticulate. Such barbaric surgeries are still done today or not? Today is all the days of imagiology. You can know the extent of tumor. If the tumor is not very extensive, why do you need to sacrifice the entire bone? Not required. So, and today is the modern day of chemotherapy. Even if skip lesions are there, you can give chemotherapy and you need not do very extensive surgery. So that is the reason chemotherapy revolutionized the management and decreased the chances of the number of nearby joint disarticulations they used to do for osteogenic sarcoma. So what is the level of amputation you need to do in case of osteogenic sarcoma is one of the favorite MCQs in entrance. Lower end of the femur, if it is occurring, then you do mid-thigh amputation and you do hip disarticulation. Upper end of the femur, if it is involving, you do hip disarticulation and hind quadri amputation. Then if it is upper end of the tibia, you do mid-thigh amputation, and if it is upper end of the humerus, you do forequarter amputation. So these are the typical level of amputation you need to do for the various levels of the tumor which you discover. Now what is the role of radiotherapy in the management of osteogenic sarcoma? That local control of the disease, to achieve that you can do radiotherapy. Similarly, if the tumor is located in an area which is surgically inaccessible, then the only option available for you is chemotherapy and radiotherapy which is available, and those who are refusing to undergo the surgery. Then earlier days, for every osteogenic sarcoma, before resection they used to do preoperative radiotherapy, but nowadays it is an obsolete procedure. Then how will you control distant metastasis of osteogenic sarcoma? So basically you use adjuvant chemotherapy, and nowadays monoclonal antibodies are there, no immunotherapy. They will go identify where is the tumor and kill it, right? So chemotherapy and adjuvant chemotherapy and immunotherapy to control the distant metastasis, radiotherapy to control the local metastasis. That is what basically is done. And lot of times a question is asked, osteogenic sarcoma is being found and there is a solitary lung lesion metastasis. Do you still want to do excision or you don't want to do excision? We want to do excision. That is considered to be your answer. So what is the ultimate role of the chemotherapy in these patients? Preoperatively you can give, postoperatively also you can give. Whenever micrometastases are there, to control the mets post surgery, you can be able to give chemotherapy. And what drugs you use for chemotherapy of osteogenic sarcoma? Methotrexate with citravoram factor. Similarly, cyclophosphamide, endoxin and cisplatinum, they are also used. And of all, which carries the worst prognosis? It is the lytic type of a osteogenic sarcoma which is considered to be a bad prognosis, is what you need to remember. That is all the story of osteogenic sarcoma. Just two more tumors before we take a break. Okay. Ewing sarcoma. Let's talk about it. Ewing's is also highly malignant, but what is the age group? 10 to 20. What are the locations? Femur and tibia. And around 1/3 of cases they occur in the flat bones. Flat bones means your scapula, etc., etc. Pelvis, calcaneum also they can occur. And what is the classical location? We said only two tumors diaphyseal, osteoid osteoma and Ewing sarcoma. And what will it lead to? A Ewing sarcoma lead to subperiosteal reaction in layers, layer after layer, layer after layer. So if you take the cut section, it looks like an onion skin, is the classical description of the subperiosteal reaction. And if you take the Ewing sarcoma, it is known to rupture through the cortex very, very early and just like osteogenic sarcoma, it also will invade the surrounding soft tissues. Let us see. So this is normal thigh, this is the thigh where you are having in the diaphysis. Are you able to see difference in the two thighs, or they are looking same? This is the thigh which has got the Ewing sarcoma. Okay, doc? This is another, from the flat bones, there can be development of a Ewing sarcoma. This is another example from the scapula, the patient is having the development of Ewing sarcoma. This is another example of a Ewing sarcoma, and this is a typical appearance of how a Ewing sarcoma look like when you happen to do MRI. Then what is the pathology, histopathology in case of Ewing sarcoma? Uniform small cells which are resembling lymphocytes. How will you identify lymphocytes in tissue through microscope? That pink spots are there, no? Like that. That's the reason Ewing sarcoma, what is it kept under? It is kept under another group called round cell tumors, they are called. There are many tumors which show similar kind of small lymphocyte like round cells. Ewing sarcoma is one of them. And the tumor cells, they all surround a clear area so that they form a rosette, which is a very important feature in case of Ewing sarcoma. And most of these cases they show necrosis, at least focally, and this kind of small pink like a rosette is a classical description in case of Ewing sarcoma. Ewing's being a malignant tumor, it goes to lungs, it goes to the other bones also. So a tumor that arises in the bone and metastasizes to another bone, which one it is a favorite MCQ of examiner. Bone to bone metastasis, Ewing sarcoma is what you need to remember. Favorite MCQ of examiner. From bone it arises, it goes to another bone as metastasis. That is Ewing sarcoma. The patient will have pain, swelling, and the very important question in the exam. There will be constitutional symptoms like fever, and the overlying area will be very warm of the tumor. Wherever fever is there and there is a swelling in the bone and which is having a overlying surface is very warm skin, then we confuse it for osteomyelitis. So this is what is asked frequently in AIIMS All India exam. A bone tumor that typically confused for osteomyelitis. What is your answer? Ewing sarcoma is what you need to basically remember. Then onion peel appearance, location in the mid shaft are the classical radiological feature. Okay, so sometimes it is confused for osteomyelitis. So let us see the Ewing sarcoma. Is it limited only to the bone or it went into the surrounding soft tissue? Surrounding soft tissues also it has gone into. And this is a typical type of a onion skin type of a periosteal reaction which you see with Ewing sarcoma. I think some smoke is coming, you can close those windows. Huh? Yeah. Now, how will you differentiate whether it is Ewing sarcoma or is it osteomyelitis? Basically, sequestrum is the nature of myelitis, and a well-developed cloacae rather than smooth periosteal reaction is a feature of myelitis, and metaphyseal location is the nature of osteomyelitis. Metaphysis had lot of blood vessels, so whenever osteomyelitis occurs, it occurs in metaphysis, whereas our Ewings occur in diaphysis. So three differences you should always remember. So how do you treat, doctor? Seminoma in surgery, right? Dysgerminoma in gynecology. Then there should be one tumor which should be called very radiosensitive in orthopedics, no? For the examiner to ask in All India PG medical,